You got a bunch of new grandbabies.
I do, yeah, we are.
How y'all doing today?
Good. Are you you're a student?
Yes, I am.
Good.
I'm Vernell.
So you're a journalism student?
No, television, radio broadcasting.
Are you?
Yeah.
Good. And what do you want to? What area do you want to go into?
This area.
Something like
television
this?
Broadcasting.
Okay.
Like my own show, something like that.
Good.
Hopefully.
Excellent.
And I was listening to the show. Excuse me. And I just want to know a couple of things. Do you think that healthcare issues are limited to only the poor and illegal immigrants?
Oh, no. Absolutely not. We're all concerned about our health and healthcare issues.
Okay.
Healthcare covers everybody, just like education covers everybody. And whenever we think of any issue, today, look what happens if they put up an electric plant in China that's a coal plant. It affects the whole world. So the idea that if something only affects one population, it doesn't affect the rest of us, it's a global world now. So healthcare affects every single one of us.
Okay. And what is tort reform, and why was it believed to lower healthcare costs?
You want me to tackle that one first?
Yeah.
Well, the idea of tort reform was we had a big problem in Texas, in that it was a national problem. We had a pretty good problem in Texas, where tort reform referred to malpractice insurance. And one of the parts that tort reform accomplished was it lowered the cap that could be paid for pain and suffering. If somebody had a medical injury and a jury awarded millions of dollars in pain and suffering, that meant that doctors had to increase their charges in order to pay for their increase in the malpractice premiums. So the charges were becoming prohibitive to the doctor, causing prices to go up. So Texas passed a cap of $100,000 for pain and suffering. And what's happened is doctors are now coming into Texas at a tremendous rate because that was keeping doctors out. But what that mainly has accomplished, it's lowered the malpractice premiums tremendously. But it's been wonderful to the doctors, and in a way it's been wonderful to the patients in that more doctors are available in Texas. But I don't see how it was expected to lower people's health care premiums. That malpractice reform only accounts for 1% of medical costs. And even if you drop that a lot, it's not going to lower premiums significantly. So it mainly was good to get greater access to doctors. More doctors are coming in, but it hasn't lowered healthcare premiums.
Okay. And y'all were talking about like wealthier people having access to a luxury healthcare. I just want to know, if wealthy people had access to luxury healthcare, would they be offered like a better doctor versus someone who has just a better class.
Basically,
they'd be offered better, medical care than someone who doesn't have access.
Well, if we had, everybody being covered by Medicare, and you'd have a nice room, but let's say somebody wanted a fancier room and their own chef and stuff like that. All the doctors graduate from top-notch medical schools, and all the nurses come from top-notch nursing schools, and the hospitals are all quality. Yes, we could do somewhat better, but that's what we're talking about, luxury care. The room would be a little bit fancier, and the food would be a little bit fancy.
Okay. And Diane?
Yes.
Will there ever be affordable health care in Texas where no matter what job you have, you'll be covered?
That's the goal. That is part of Texas' plan. Getting there is the real issue. The number one fiscal responsibility of Texas is public education. And so there are only two cost drivers in the Texas budget that really matter. One is education, and the other one's health care. And sometimes when we think of health care, we think of us going to the doctor in the hospital setting. You know what the greatest cost of health care is in Texas? Nursing homes. And that is going to continue. So we have to deal with our aging population. We've got to think of new ways to keep people in their homes, keep people healthy. And so, as my parting shot, I want to really encourage people to stop smoking, to always wear their seatbelt, to lose that 10 pounds that they've been wanting to lose, and to strap on their tennis shoes and walk in their neighborhood, because personal responsibility is, when you do those things, you're going to feel better, and you'll have less chance of ending up in the emergency room.
Lowering your health risk.
Yes, ma'am.
Okay. Well, anyone else have any questions? That's all I have today.
Is there some kind of perspective? For example, there are some things, for example, nurses could do, but they're only allowed to do by doctors, for example, administering shots and that sort of thing. Is there any kind of discussion about, possibly changing that to where health costs could be lowered by having certain elements where only certain things nurses could just take care of instead of having to go see a doctor?
There's a big effort right now from nurses in various sectors to have expanded responsibilities. I think that their advanced practice nurses already can do some of those things in rural areas. They would like to see that practice expanded. And it's happening in all sectors of the healthcare business. Dental hygienists would like to have expanded responsibility, and optometrists would like to have expanded responsibility. So it's called scope of practice. Those are really important issues in Austin. We want to be sure that the health and safety of the patient is assured. And so there needs to be a thread of protocol, of supervision, and it's a great question because those are issues that are debated in Austin right now.
Would doctors feel threatened by a reform like that?
No. As a matter of fact, I think it's going to come sooner than a lot of people realize. One of the things that we're facing down the road is you got to have a long view. And we're focusing on access and cost, but there's a lot of other issues going on. And one of the things that's going to happen is, as people my age and younger start to retire from the medical and nursing profession, we're facing a huge shortage down the road of doctors and nurses. We don't have enough medical schools, we don't have enough nursing schools, and we don't have enough faculty. So even though we're going to start drawing on nurses to help out doctors and do more medical things, that's only going to put a strain on the shortage of nurses that we're facing, which may be more than the shortage of doctors. So that's why the comment that one of the people made about the czar, I mean, we've got to have a much more comprehensive approach. We can't just have this piecemeal approach where somebody's looking at Texas and somebody's looking at California. We're all in this together, and healthcare is much more complex, and we need a czar to knock heads.
May I add something to your comment, which really brings this issue of nurses home? Right here at Central Texas College and Temple College, the last summer we had 200 students that wanted to matriculate into the nursing programs. We didn't have faculty or facilities in order to, those students all qualified, but we didn't have the infrastructure that would allow that growing nursing class. And we're importing, Texas is an importer of nurses. So they're nurses that come from the Philippines that are studying for our exams to come into to Texas hospitals. So this issue of the availability of workforce for not only doctors but especially for nurses is at a critical point in Texas.